remember that all of us share into this knowledge about tetanus guidelines. So thank you so much. Without any further ado, we are going to flash the agenda so that everyone is on the same page with us. So our agenda, we shall have our opening prayer, and then here we shall expect someone to, a volunteer, to give us a prayer. We shall have welcome remarks by the moderator, and then we have our friends, Meisha Med. They'll have to also do a small presentation, and then we shall introduce BHF to everyone. We shall have the presentation by Dr. Nicholas Mugagga, and then Q&A, and then we shall have the closing remarks. Without going into any other details, let me request a volunteer to give us an opening prayer.
Can we humble ourselves for a word of prayer? Lord, we thank you for this time. We thank you for this evening, for this meeting that we are yet to take. I pray, Lord, that you'll grant the moderator and the person presenting wisdom, knowledge, and understanding. And I pray that we shall grasp everything and put it into order. For in your name we've been able to pray and believe. Amen.
Amen. Thank you very much. We are now in the hands of God, and whatever we are going to discuss is for the glory of God, the well-being of the people. I'm Pontian Chiwanka. I'm an obstetrician from Uganda General Hospital and a member of BHF, that is Busoga Health Forum. But I shall tell you more about Busoga Health Forum. Those who are on the call, you have seen the good, the wonders that they are doing, or we are doing for our wonderful people. Before I go into that, let me call upon Maisha Med to give us a small presentation. Maisha Med, you are welcome.
Okay, thank you, Doctor. I'll skip on behalf of Maisha Med. Now the person has not yet logged in, but members, Maisha Med is a company which is having a digital platform that can help you in case you're having a pharmacy, a drug shop. They have a software which you can use to able monitor your sales, able monitor your stock within your drug shop and pharmacies. So if you want a software that is easy to install, easy to manage, this is on a tablet format and it's not very expensive. They are having an offer. If you're buying it through Busoga Forum, with 100,000, you can have an installation within your pharmacy and drug shop at 100,000. So in case you are interested, kindly you will inbox me and I can support you connect to Maisha Med. Maisha Med sponsors our CMEs and we give them credit and we thank them for that. So that's a brief information about them, and they'll be coming to us next week to make a presentation. But you can support them. Their software is really good and it's easy to manage. Where you are, in case you're not able to be at your pharmacy or drug shop, you can monitor it using your phone and you can monitor everything that is happening within your business. That's it about Maisha Med. Thank you so much.
Thank you so much for the brief introduction. Please, members, let us make use of it. And this is the Busoga Health Forum. A brief about Busoga Health Forum is an association of like-minded people and professionals stimulating community, government, and partner actions for better health of the people. As you saw the introduction and the videos that we are playing, we are a national, not-for-profit, voluntary membership-based organization, and we are headquartered in Busoga City. BHF works in collaboration with the Ministry of Health local governments, civil society organizations coordinate the interventions through established technical working groups and technical administrative structures, including district health teams, formal and non-formal community structures. And the WHF is therefore a think tank generating evidence to drive health policy action to improve the health and development of individuals in Busoga and beyond. And we encourage everyone to join Busoga Health Forum wherever you are, whether you are in Busoga or outside Busoga, outside Uganda, wherever you are, please join and let us push the health, let us improve the health of our region. So I think that's a bit of the introduction. We are going to, okay, our core program areas: reproductive, maternal, newborn, child and adolescent health, RAMNAG. And you know this one is the backbone of health and therefore socioeconomic development of any given country. Malaria, HIV and TB, we delve into that, many programs, regional planning, and national planning. Busoga Health Forum is among, and also pushing the policy forward. So once again, we call upon all members. Subscription, as you can read, we have the annual, we have the lifetime. Become a member. We have institutions which can join. We have individuals who can join. Please, wherever you are, it doesn't discriminate between maybe among religion, tribe, age, professional. So please come and join and give us the knowledge how we can move forward and also improve the health of people from Busoga and also Uganda at large. Thank you so much. So we are going to call upon our presenter for today. And the brief about our presenter for today is Dr. Nicholas Mugagga. I'm going to read it to you, the topic, but the topic I think all of you have, seen it. Dr. Nicholas Mugagga is a prominent doctor, a clinical doctor, who graduated with a Bachelor of Medicine and Surgery and a Master of Medicine in Obs-Gyn from Maternal University, Kampala, Uganda. And his research interests are focused on maternal immunization in pregnancy, with the publications in international medical journals. He's a passionate, experienced obstetrician and gynecologist with over 10 years of experience in clinical practice. He offers women health services, pregnancy care, minimally invasive surgeries, that's laparoscopy, pediatric and adolescent gynecology, investigation and management of female and male infertility. He serves the Kingdom of Uganda as a member of Uganda Kingdom Medical Bureau, a body that oversees the management of all the hospitals owned by Uganda Kingdom. He is the health in charge of Busiro County, which are 10 counties of Uganda Kingdom, where he has excelled in serving the people of Uganda Kingdom. Ladies and gentlemen, the presenter is also a charter member of the Rotary Club of Wakiso, where he has served on several boards of the club, leading the health activities in the club. He is also a member of the Central Advisory Committee of Tasso Mulago and is responsible for mobilization of resources to offer comprehensive HIV care and treatment for Tasso. And I'm sure as he leaves, he will also gather and mobilize for us resources, because we are also dealing in HIV care and TB. He also serves his church as a patron of the Xaverian movement. This one helps to shape the younger Christians into good people. And he's a member of the AOGU. He's a member of so many professional bodies, Fertility Society of Uganda, EXAPOG, all those bodies concerning with the women's health, is a member. So a lot can be talked about Dr. Mugagga, but then we have to save time, and we call upon Dr. Mugagga to make his presentation. Dr. Mugagga, please, you are welcome to address this forum.
Let me make an announcement before Doctor comes in. Members, the registration link is always shared 45 minutes after the session. And this time round, we are requesting all professions, nurses, clinical officers, dentists, lab technologists, kindly register using the link that will be registered, that will be sent in the chat box. Thank you.
Thank you very much. I think at this juncture, let me call upon Dr. Mugagga to make his presentation. Thank you very much. As he's preparing, we are going to look at why guidelines on tetanus vaccination in pregnancy should be reviewed. Dr. Mugagga, are you on the call?
Hello, Dr. Mugagga is online. I don't know why he's not able to speak.
Yeah, he's online. Is he muted?
Let me sort it out.
Okay. Yeah, it seems to be still muted. As they are sorting him out, the topic I've read through why guidelines on tetanus vaccination in pregnancy should be reviewed. As we are waiting for him to unmute, you find that we have so many papers published about tetanus, and we had one which was published by Nanteza, Barbara, Moses Galukande. Sorry for not putting their titles, because I read through the papers and this is what I found. And then Anthony Kembonye, and they were looking at tetanus, which was on the increase. That's by 2016. It was on the increase, especially among the 5 years plus. And then we have another paper which was published by Kazibwe, Felix Bongomin, Dr. Majid Kajimu, who are looking at tetanus affecting majorly the males. They looked at the admitted people from 2011 to 2020 and found out that males, 85% of males who were, of those who died were males. Today, we are looking at immunization of pregnant mothers so that we can stop tetanus in the neonates. Dr. Mugagga, are you able to unmute? Dr. Mugagga Nicholas, we are waiting for you to unmute and start the presentation.
Yes, Dr. Mugagga has been having some technical issues with gadgets, but he's joining and I'm supporting him to be here.
Okay, thank you so much. Immediately he unmutes, he's going to start. as I was saying, that WHO validated Uganda as having achieved the maternal and neonatal tetanus elimination by 2018. And then we are encouraged to observe cold hygiene, mothers deliver in skilled hands, and also child care, and also observe the maternal immunization. We want to learn today more why Dr. Mugagga is saying that the guidelines need to be checked, need to be changed.
Dr. Mugagga is back. Dr. Mugagga, can you unmute?
Dr. Mugagga, please unmute and start the presentation. Thank you so much.
Dr. Mugagga, still are you able to unmute? Just click the microphone just below your phone and you're able to speak.
Dr. Mugagga.
Excuse me, I'm so sorry about that. I hope you can hear me now.
Please, we can hear you. Go on.
Thank you so much for the opportunity to present to the Busoga Medical Forum. I bring you warm greetings from Uganda Kingdom, from Mugagga Hospital and St. Joseph's Hospital, Wakiso. I'm Dr. Nicholas Mugagga, obstetrician and gynecologist in Mugagga Hospital and St. Joseph's Hospital, Wakiso. I'm here to present to you about our research findings for which we did a study in Kawe in the year 2020-2021. And it's a basis from which I think our guidelines about vaccination in pregnancy need to be used. Neonatal tetanus remains a preventable cause of neonatal deaths, despite Uganda having reached 81% TB vaccination coverage in pregnancy. Ideally, the recommendation
Excuse me, Doctor. Excuse me. Could you reduce this? Could you mute one of the devices when you're using to present? Just put the volume down so that we don't have an echo. Just remove one of the devices off because you're having 3 devices. So unmute them so you don't have an echo.
Okay, I'm sorry. Can you hear me now? Am I clear now?
Yeah, you are clear.
Thank you so much. Despite us having reached 81% vaccination coverage, neonatal tetanus is still a problem in Uganda. The WHO refers to tetanus as a silent killer because many of these babies die before diagnosis. I mean, the diagnosis of neonatal tetanus is bad if you've had a neonate that has been suckling and feeding well in the first 2 days, who suddenly stops feeding, then they become paralyzed, convulsed, and die. Unfortunately, most of the times we can't diagnose these babies before death. Many of them die without registration. And for those that get tetanus, even in the best hands, you have mortality of close to 100%. Even in the for facilities that have ICU, you have deaths that go up to about 20%. One scholar called Chu Englund in 2014 showed that the efficiency of antibody transfer is low until about 32 to 34 weeks. Actually, in the first trimester, where we quite often attempted to vaccinate our mothers that come in so early during antenatal, there is no transfer up to about 13 weeks. If you give a vaccine before 13 weeks, it won't be transferred because the placenta then doesn't have the ability to transfer these antibodies. The transfer gets better between 17 and 22 weeks, where you have about 5 to 10% transfer of these antibodies through the placenta to the mother. So when you vaccinate a mother around that time, you may have about 5 to 10% of them that transfer those antibodies. The transfer is about 50% when you get about 32 weeks. So when you vaccinate so early during the pregnancy, you're actually not helpful to the mother because the placenta then is not able to transfer these antibodies to the baby. We need to realize that according to Liang et al. In 2018, these maternal antibodies are estimated to wane out within a year from the date of vaccination. And it's very important to note that the rate of decay of these antibodies is consistent regardless of the amount of antibodies received. The current myth of the thought that once you've done 5 shots in 5 years, if you've done 5 shots in the reproductive years of between 15 and 49 years, you're covered for life is not true at all. It's disputed by most of these scholars. And it's clear that even if you got 5 shots in a pregnancy, within 1 year, you don't have any antibodies that are protective to this newborn. Unfortunately, as I'll show you, our guidelines of 2022, you can actually find it on page 3 of our guidelines. This contradicts most of the other international recommendations. Most other recommendations like ACOG, the CDC, the Royal College of Obstetricians and Gynecologists all recommend that you need to get a shot of tetanus between 27 and 36 weeks of gestation. And the reason is basically because after you've gotten vaccinated, it takes about a month for the antibodies to build up to be protective. And you want to target the delivery of your baby at the peak of antibody production.
Excuse me, doctor, I need to move the slides if you are controlling the machine. Thank you. Please go on.
Okay. I was still saying that most recommendations from all the international bodies want us to vaccinate between 27 and 36 weeks. And the reason is you need to have the vaccination to have the delivery of the baby at the point of the peak of production of antibodies. And these antibodies take us about a month from the time of administration to reach the peak. That means that if you're giving your shot earlier on in pregnancy, in the first trimester, it's now very clear that you're not doing any transfer until about 17 weeks. At 17 weeks, the transfer is very low, about 5 to 10%. And someone has removed the screen. Okay, you moved ahead of me. Yes, thank you. You're not having any transfer. And for us to sustain this elimination, Uganda was declared to have eliminated tetanus in the year 2011. For us to be able to sustain that elimination, we need to ensure that we do the right practices. We need to vaccinate at the right time, such that the mothers have adequate transfer of antibodies to their newborn. And in our study, we aimed to determine the prevalence and factors associated with transfer of protective levels anti-tetanus antibodies among the newborns. And this, next slide. This is our guideline of 2022 vaccination guideline schedule. And it's clear when you get to page 3 of that guideline, you were told to vaccinate in the first trimester. Research has shown us that once you're doing it before then, you are not achieving anything. Still, the guidelines go on to tell us that you give the second shot between 13 and 28 weeks. Still, please note that at about 32 weeks, you have about 50% transfer. And that time around, between 17 and 22 weeks, you only have about 5 to 10% transfer of antibodies to the newborn. So vaccinating so early, as our guidelines tell us, is actually not a right practice that I believe could be the reason why the figures are getting high with tetanus vaccination. I mean, with rates of neonatal tetanus. Next slide. This gives us a brief about the figure. When you look at March 2023, it's evident while we had suppressed previously, probably because we are not vaccinating at the right timing, the figures are beginning to go high. This was extracted from the DHIS tool 2. This is where we all record our findings. And remember, many of the babies because they probably are not diagonizing as they should be diagonizing. Next slide. From our study, these are the methods that we use. We did a cross-sectional study where we had 293 mother newborn pairs at Kawempe National Referral Hospital. And this was from the 1st of February to the 31st of March 2020. And we recruited these mothers at the point of admission into the labor suit. We gave them a questionnaire that they filled, and whoever was ready to be part of the study consented to the study. And at the point of delivery, we drew 2 mils of maternal blood, venous blood, and 2 mils of fetal venous blood. This blood was centrifuged at about 1,500 revolutions per minute and separated the liquid. And this was transferred to Makerere University for storage at between 2 to 8 degrees Celsius. And this was analyzed using a commercially acquired ELISA kit. And for us to determine that this baby, all mothers had adequate transfer of antibodies, WHO recommends that any baby that has gained greater than 0.1 international per mil was considered to have received adequate antibodies. And these are the ones that we considered to have acquired adequate antibodies that were high enough to protect them from tetanus until their next vaccination that usually takes place at about 6 weeks from birth. And from this, we still established the factors that were associated with transfer of antibodies using a generalized linear model family with a log-in and robust variance estimation. Next slide. Next slide, please. These are the findings of our study. We found that the mean maternal antibody titers were 3.63, and the mean neonatal antibody titers were 3.7 international units per mil. From the recommendations of the WHO, anything that is greater than 0.1 international units per meal was considered adequate. And this tells us that actually our mothers have adequate antibodies, and the TD antibodies in the mother determine how much will be transferred to the newborn, as you clearly see. And the newborns actually showed that you have about 88% transfer among the newborns that came out from our study. And if you look at the 99.9% in the mothers, this clearly tells us that the higher the antibodies that the mother has in their circulation, the higher the likelihood of transfer the newborns. That's why the figures rhyming with what we saw in the neonates of those mothers. Next slide. Please continue. Let the graphs come. These graphs try to explain our findings diagrammatically. When you look at the maternal side, the higher the antibodies that the mother has, that directly translates in how much the newborn baby to receive from their mother. And this linear curve also explains that. When you look at the blue line, we considered mothers that had received their first shot of tetanus. Sorry, those that came in for the first antenatal before 28 weeks, and those that came in after 28 weeks. You realize that from then, those that had received their tetanus shots shows that there's a positive correlation between how much the mother has and how much they can transfer to their newborn. So the higher the maternal antibodies, the higher the transfer that is transferred to their newborn. Next slide. What everyone of us that is listening in needs to take home as a strong and very valid take-home message is that the timing of the shots matters a lot. From all the literature and our study findings, realize that it's common practice that most of our mothers come in a little late in the, usually sometimes come in the third trimester. And the question is, she has come in at 34 weeks. Can I vaccinate her? The answer is yes. Remember, for you to have adequate transfer from the time of administration, it takes you about 4 weeks. So you have time anywhere between about 27 weeks and 34 weeks. So don't refuse to give these mothers their tetanus shots because they've come in late. And it's also very important to note that in our graph there, we compared mothers that had received their tetanus shot before 27 weeks. This clearly shows that those that had received their tetanus shot before 27 weeks didn't have adequate transfer of antibodies. While those that had received their tetanus shot after 27 weeks, their antibodies the mothers had transferred adequate antibodies that are way beyond the 0.1 that is recommended by the WHO. That still emphasizes the fact that we need to vaccinate our mothers after 27 weeks of gestation, before 34 weeks of gestation, as recommended by other bodies and other research and studies that are done elsewhere. Please continue. The neonates of mothers, this actually explains the curve. There is okay, thank you so much for getting back. In down there, you realize that the the ISP recommends that mothers should receive a TD shot at about 27 weeks, but before 36 weeks of gestation. So that should clearly get into our minds that anything that is happening before 27 weeks, you'll have a peak in about a month's time. Then after the peaking, the antibodies begin to drop. And after that drop, you'll definitely deliver a baby at the point when the antibodies have dropped. And remember, you have about 6 weeks from delivery, the next dose of vaccination during our vaccination schedule. So let's try our best to ensure that we vaccinate our mother in that time duration. That's what ICP recommends, and that's what our study also found. Next slide. We compared the common myths that we all have had or read about, and these are guidelines that we often refer to that tell us about vaccination of our mothers. Having 5 shots that give them lifetime protection from between 15 and 49 years were published in 2002 by the WHO. And that's what we still have in our minds. That's about 20 years ago. The rest of the world has moved on, and it's evident. And those other recommendations I'm talking about of our book were published in 2012. That's still about 10 years ago. But unfortunately, we are stuck on our 5 shots for lifetime production. Our study still disproved that myth. It's very evident that those that received more than 5 shots of tetanus didn't have any advantage over those that didn't receive the 5 shots of tetanus. Actually, we actually found that those that just got 1 shot of tetanus but had adequate transfer of antibodies as long as it was given at the right timing. But we also had mothers that had delivered previously. For example, the assumption is if, for example, you have a gravida 8, they've gotten over 8 shots of tetanus. If they didn't receive their other shots, as the current practice and teaching is that once you've gotten more than 5 shots, you don't need any more shots of tetanus. Those mothers actually didn't have adequate antibodies transferred to their newborns. And these babies were at a risk of getting tetanus because we found their titers of the antibodies at less than 0.1 international units per mil. So the myth that you have 5 shots, you have lifetime protection does not count anymore. So that needs to also be erased from our mind to have better results for our mother. This looks at other factors that we considered while we did our study. What comes out clearly that maternal antibody titers directly translated into how much transfer their newborns have. And from that, you see a p-value of 0.02. That is, the level of significance there is really high. So it's evident that once the mother has the adequate antibodies, their newborns will have adequate antibodies, receive that delivery. The gestation at the last tetanus shot was equally very important. The mothers that got the vaccination after 27 weeks, like the other recommendations have told us, their p-value was as high as was 0.034. That is equally significant. The number of TD shots in the current pregnancy was equally found important. Those that had more shots of tetanus definitely had more antibodies that they received during the vaccination, and that equally translated into adequate transfer. But with our challenges, I don't see why we have to give 5 shots or 3 shots, because right now the teaching is once you come in, first time we give you a shot, then give you another shot 1 month later, then give you another shot 6 months later. That means that mothers that come in for antenatal will get up to about 3 shots in their pregnancy. The truth is, from the literature, those that we give in the first and early second trimester don't give us adequate transfer. It's only that last one that we get in the third trimester that actually gives us adequate transfer. So having to waste the other two, which we clearly have evidence now that they are not helping the mother, shouldn't be practiced. Maternal age wasn't important in our findings. Still, HIV infection wasn't found significant. However, our other studies, most chronic illnesses like HIV, diabetes, actually showed that if you have had a chronic illness in your pregnancy, that affected transfer of antibodies. Actually, malaria inclusive. If you've had malaria during your pregnancy, you would also not have adequate transfer of these antibodies to your newborn. We probably think our sample size wasn't good enough and we didn't have as many HIV positive patients in our study. That's why it probably didn't come out as it came out in other studies. And very important to note also down there is that the tetanus shots got before the current pregnancy were equally not significant. It's important to note that from a study that was done by Liang in 2018, that these antibodies were around within a year from the time of administration. And it's also very important to note that the rate of decay of these antibodies is consistent regardless of the amount of antibodies received. So even if you give this mother the 5 shots in one pregnancy, they will definitely need another shot in the next pregnancy. So giving more than 1 shot in a pregnancy does not guarantee that these mothers have adequate antibodies, and they will equally need antibodies for their next, they will need tetanus shots for their next pregnancy. In summary, these are the conclusions and recommendations. From our study, we found that there were high rates of maternal neonatal transfer protective antibodies, and the reason is we actually give, if someone comes in early, we often give them up over 3 shots in their pregnancy. A TD shot between 27 weeks and 36 weeks of gestation offers the best transfer of antibodies to our newborns. So I suggest that we adopt that, just like other international bodies like ACOG, the CDC and other bodies that have done studies have actually documented and recommended that for their countries. We hope that this will also be looked into, such that we also move our guidelines to that, such that we have our newborns adequately protected against tetanus. We need to note that each pregnancy requires a tetanus shot, irrespective of the previous number of tetanus shots received previously. For the same reason I've explained, after 1 year, you don't have any adequate transfer of antibodies, and antibodies that are still in the mother's body can never be high enough to protect the baby from the time of birth through the 6 weeks when they'll get the next shot of vaccination at our immunization schedule that starts at 6 weeks. We hope to do a bigger study with a bigger sample size. This was done in Kawempe. We probably look at doing other studies in the regional referrals and the other parts of the country to see if it's the same as it was in Kawempe. But the findings in Kawempe are not new findings. They're actually just trying to prove what the rest of the world is doing. So the studies may or may not come, but other studies have done, so other countries and other bodies have done such studies, and the recommendation is still the same. I believe we just have to adopt and move on to what the rest of the world is doing. The notion that 5 shots of tetanus give you lifetime protection should be discarded. Every mother should get a shot of tetanus for their protection. Next slide, please. These acknowledgements of the people I worked with for this study, my supervisors, Dr. Mr. Sechikubo, Professor Net Nachimuli, Dr. Bagaya Moses, Dr. Milton Nsaba, Mary Fahad, these were PhD students. Pepi did part of the funding of this study with Assistant Professor Chiguli and Dr. Mkunya David, St. Joseph's Hospital Wakiso, and Uganda Kingdom for the support and the funding to help us come up with such findings that we hope, if looked into, we should be having better guidelines such that we better vaccinate our mothers who at the timing when they really shall benefit from the tetanus shot. Thank you so much for listening.
Thank you very much, Dr. Mugagga Nicholas. That was a fantastic presentation. We thank you so much. We are going into the period, the time of questions, and then we shall receive the answers. But to remind everyone, today has been the 38th NRM Victory Day anniversary celebrations, and the theme today has been building a country we all cherish. Thank you. We are waiting for the questions. Others can go through the chat, but we shall also look at those ones which are going to come, those who will put up their hands to ask questions. There is one which I saw in the chat, which was saying how many doses of TD should a mother get during her pregnancy. So that was in the chat, but we are also going to receive others as we go on by Dr. Mugagga. Someone is talking. Yeah, thank you so much. But also, I would like also to ask whether PET, which also affects the placenta, has also an effect on the transfer of antibodies. Members, let us show up, raise our hands and ask questions to the presenter. Thank you so much, members. I've not seen a hand yet.
There's a hand for Matova.
Oh, yes, please go on.
Thank you, Dr. Nicholas. Matova John is my name. I'm listening in from Nairobi. The presentation is really nice, and thank you for the good work that you have done. I have a few comments. One from the slide on the Uganda tetanus vaccination guidelines, which shows that there are 2 doses recommended in the early pregnancy. Need to remember the weeks. First trimester 0 to 12 weeks, and then later on 13 to 28 weeks. So if all mothers who seek ANC services receive those 2 doses, do you think they will be covered by your recommendations? Because from your presentation, we saw that vaccination from 27 weeks onwards is protective. The other question is from the slide which shows the monthly trends for neonatal tetanus, which clearly shows that from around March 2023 to September, there were so many cases of neonatal tetanus reported. And this is so much different from the trends from 2021. I find this something may be related to, is it improved facility-based deliveries or improved reporting rather than inefficiencies in the vaccination program? Since I don't think there are any vaccination changes that have taken place from 2021. The last one is based on the results. We saw that the more the number of TT vaccinations during pregnancy, the more the protection. We saw that from the p-values of having 0 to 1 as the reference category, then 2 and then 3 and above, we saw that the p-values were more stronger. So in that regard, do you recommend 3 and above vaccinations during the pregnancy, even if the vaccinations start at the earliest possible time during pregnancy? Thank you.
Thank you very much. Let us have Jessica Tugonza. I hope Dr. Nicholas is writing down these questions.
Yes, I am writing them down.
Please, Jessica, go on.
Thank you so much for the presentation. It was really awesome and educative. My concern is I'm kindly requesting Dr. Mugagga to share with us the link to the article so that we can access it, or maybe what we could, if it is available, and we could easily access it on Google. Thank you so much.
Thank you very much. Jessica, let us have Professor Peter Waiswa.
Thank you so much, Dr. Mugagga. I was once an intern at Rubaga, and I think it's a very good presentation, and it says a lot of things about our system. I mean, we have WHO here, we have CDC, we have Ministry, the Association of Gynecologists, and the rest of us, and others. And then the guidelines, international guidelines, say something different, and then we are practicing old style. So I hope maybe that session can be able to help the ministry review guidelines in general to see how update the guidelines. And there are so many guidelines across the board that need to be improved. That is a general thing. And as you said, I don't think we need another study like yesterday, because we just, I mean, all the evidence from other studies and guidelines basically point to the same. So I don't think we have any special circumstances in Uganda that might make it different. I think we have just confirmed. So 2 questions. One is, what are you doing to, I know this is part of the dissemination, but of course the Ministry of Health is the one which makes guideline changes. How are you engaging with the ministry? The second one, you are basically saying that all vaccination before that window are useless. Does this also relate to vaccination of teenagers, which is encouraged as part of school programs? Are they also a waste? I think those are the 2 questions that I have. Thank you.
Thank you very much, Professor Waiswa. Let us close this session of questions with Katerina Bosco. Then we shall have another set of questions after Doctor answering these questions. Katerina Bosco.
Thank you so much, Doctor. I am Katerina Bosco from Buvuma District. Actually, one of my questions has been asked by the person, the person who has just asked. Let me go straight to the second question. Looking at the guidelines in place, which are a short on the first contact with the mother, and then a second at a month, and then the third at 6 months. I want to ask Doctor about these findings, this new research they made. How will they implement? How would they implement these shots to the mothers to give life protection? Because it's like this, the guidelines in place, according to his research, are not giving ultimate protection to the mother and the baby. So how will be the flow of their new guidelines to give protection to the mother fully and the child? Thank you so much.
Thank you very much, the participants. Dr. Nicholas Mugagga, please go on to answer these questions, and also we shall look through the chat, other questions. Thank you so much.
Thank you, colleagues, for the questions. I'll start with Mr. Katerega Bosco, the last person that questioned. The question was how will they implement guidelines that will give you lifetime protection against tetanus? Tetanus, you can never ever get lifetime protection against tetanus. While my study was focused on pregnant women, actually, there was an article in the Monitor on the 15th of this month. There was an evidence that the boy child was left out because the focus is on the mothers. And it was evident that actually, despite the neonates, there was a rise even in other age groups and populations in Uganda. So for us here, when you get a wound, you must get a shot of tetanus. And like I've said, these antibodies were out within a year from the time of administration of vaccine. So once you have a wound and you didn't get a shot of tetanus in that 1 year, please make sure you get a shot. And you need one shot for you to have antibodies in your body. From the time of injury, it takes us about 7 to 21 days to have the tetanus bacteria build up in the body to get us the symptoms that finally claim most of us. So whoever gets needs to get vaccinated. There's nothing like lifetime protection against tetanus. Then I'll go back to Professor Waiswamai Obi at Mugagga Hospital. I'm happy to learn that you went through their hands like I have. The first question was dissemination. I was at Tawogu, the first dissemination activity was at Tawogu. I was at a conference in Tawogu and I had my presentation there. I should also be able to come up with the Tawogu of Eastern Uganda. My article is already there. I'm here at Abusoga Medical Forum. I'm looking forward to such opportunities. I've also been to media houses to disseminate this. And I'm engaging the ministry. I've written to the commissioners for an opportunity to allow me to disseminate to them, such that our findings can make value to our population that we serve. The vaccination of teenagers is not a waste. Like I said, this study was biased mothers and the newborn. The general population, whether teenagers or anyone that is that has had a penetrating wound with anything, is a candidate for tetanus infection. So whoever has a wound must get a shot of tetanus. And it's recommended to get booster doses at intervals of about 2 years to make sure that we don't get infected with tetanus. So the teenagers and other age groups need to be vaccinated against tetanus. Like Dr. Waiswa said, my research is actually, our research, not my research, is not finding out anything. It's actually affirming what other bodies have been doing from as early as 2012. That's about 12 years ago. The guidelines that tell us to vaccinate the 5 shots were published by the WHO in 2002. Probably the study was done in the late 90s, and that's what we practice. All I'm saying is that we need to move with the trends such that we practice what works for our mothers, that is already practiced elsewhere, that has been proven, and there is evidence that one shot of tetanus works. And if given at the right timing, between 27 and 36 weeks of gestation, you have protection for that pregnant. When you get pregnant again, actually one study showed that even if you got pregnant within a year from delivery of your baby, still the antibodies are not high enough to take your next pregnancy. So you must get a shot for each pregnancy. Jessica asked where to find this information. We publish with a BMJ, so you can find the publication there. Mugagga et al., the tetanus study. When you get to the Mr. Google, you'll be able to find that study. It was published at BMJ. Then Mr. Matov asked, The first question from Mr. Matov was about whether the TB vaccination guidelines in Uganda, I need to be reminded, I seem to be forgetting the question. Please, Mr. Matov, have a minute and remind me. Then about the monthly trends in the tetanus figures. These extracts were gotten from DHIS2. It's a tool where we report our findings. You realize that while those cases came up, the figures could probably be much higher because tetanus never gives us time to diagnose it. The symptoms, it's main a clinical diagnosis. You've had a baby that has been very lively, suckling so well in the past 2 days, then suddenly they can't suckle, they are convulsing and dying. We often treat it as HIE. Maybe it could be tetanus that we are misdiagnosing as HIE3 because of the convulsions. For babies that have been very stable, because you know clearly that HIE will not give you certain symptoms. You've had a bad outcome from begin to convulse and shortly dies. We probably are underdiagnosing the cases of tetanus because we are not, we probably had taken our minds off. So I believe we probably had more time to think through the diagnosis and probably diagnose better. We may actually have worse figures. That's been to actually struggling with high numbers. And what is really worrying is that the treatment is very high, sorry, very expensive. And even in the best hands, if you have no medical care, you have about close to 100% mortality. In best hands, where they have an ICU, and if you look at how Uganda, how many facilities have ICU? And even if you have ICU, how many of us Ugandans can afford to be in ICU for a month? That's for a few privileged Ugandans that will be able to benefit from ICU, but most of us, the common people, may not be able to benefit from ICU because we can't afford it. Based on the study, it is evident that the more shots of tetanus you give, the higher the antibody transfer. That is very true. But if one shot works for you at the right time, why don't we shift that funding or that money to some other thing? I mean, the number of health challenges in our country that haven't been addressed. So I don't agree with wasting. I would call it wasting the 3. Yet 1 is equally adequate and protective. That's why I say we need 1, just like other scholars and other studies found out, 1 for each pregnancy. Reserve that money into something else that can be beneficial to the nation. Someone asked about whether PET would affect transfer of antibodies. Our study didn't find that. And like I said, most of the chronic illnesses, including malaria, HIV, diabetes, most of the literature clearly put it that once you've had that, have lower titers of antibodies transferred to the newborn. We can know that PET equally affects the function of our placenta. I think PET would definitely reduce the transfer of these antibodies, but I can't be clear on that because we didn't find it in our studies. And most of the literature was silent about PET. I didn't find an article that would talk about TD. Then someone asked how many days of tetanus should a mother get during pregnancy. What we do currently in most of our health facilities, once a mother comes in so early, we give them a shot immediately, most likely in the first trimester. Evidence tells us that before 13 weeks, that placenta doesn't have any transfer that is possible. So when you're doing that, you're wasting the drug definitely. When you go to the first trimester, it clearly shows that between 17 weeks and 22 weeks, you have about 5 to 10% transfer. That's still wasting. Actually, one other scholar shows that at about 32 weeks, you have just about 50% transfer. So when you're vaccinating before 30, so early, you're probably missing out. So the recommendation is 1 shot between 27 weeks and 36 weeks. that is adequate to get you as much coverage as someone that has had 5 shots. And even if you've gotten 5 shots before your current pregnancy, that doesn't give you lifetime protection. You'll need another shot for your pregnancy because these antibodies will be worn out within a year from the time of administration. Thank you so much. That's the response to the questions I got. I wonder if there are other questions.
Thank you so much, Dr. Mugagga. I see so many hands, but my administrator will not allow me to continue because it's already 7 minutes late. And please, Dr. Mugagga, provide your line, your contact in the chat, which is on WhatsApp, so that people can, those questions can come to you. And then in the chat, there are so many links for the BHF, that's Busoga Health Forum, a group if you want to join, and also other registrations. Please check in the chat. Dr. Mugagga, provide your line so that people can ask you. Otherwise, we are already 7 minutes late, and I would like to get remarks from Busoga Health Forum board member. This is Busoga Health Forum, not medical only, but we cover everything about health. I see members are dropping off. So I call upon the board member, probably if Professor Weiss is still on call, to address and also give us the closing remarks. Thank you so much.
No, I just want to thank Dr. Mugagga. I know that you presented this elsewhere. This is a very important study, and I think it has a lot of implications. What else are we doing wrong? And yet we are all here as scientists. What does it take to adopt policy or adopt policy that already exists elsewhere? And for many of us in medicine, I always say medical school is one of the worst places to learn because we sort of learn things like facts. You learn once and sometimes you think things don't change. But the fact is, now we find that most of the things we studied are no longer true. I mean, like saying chloroquine may not work. In some places, chloroquine is going back, or so many things can change. So I think that is so important that to realize that we need to continuous medical education, but also we need to review our guidelines regularly. I'll definitely reach out to also the commissioner in the ministry about this issue. Thank you so much, Dr. Mugagga. And usually we do a certificate. So there is a certificate from Busoga Health Forum. Thank you for coming from Uganda to do the needful in Busoga. But as you heard, some people are coming from Nairobi and further. So this presentation has gone beyond Busoga. Receive this certificate from Busoga Health Forum. And thank you so much. We invite you once again. And Dr. Ponshan, Chuanka, thank you for the good work you are doing in Uganda. I hope you can even, changing a practice without changing the guidelines can be considered illegal. But maybe you can do the best judgment and decide to implement this already in Uganda and the region. Thank you so much, members. Come back to Busoga Health Forum next Friday and have a great weekend. Thank you.